We have a really interesting session, right? And it's PCOS demystified, body, mind, and beyond. Polycystic ovarian syndrome, I think, it really, I think, the disease burden, not all we know, it's very high in globally as well as in India. But if you see, that, remember why we actually discussing and really elaborating on this topic in the month of September. Usually the September month being celebrated as morely towards like raising awareness on PCOS. And when we talk about the disease burden, particularly in India, I think what we say like affecting 1 in 5 women like having this challenge of PCOS. So if you really contributed like 17 to 35% of women actually suffering with PCOS. It's not really, it's just not the disease. I think it's also affecting the infertility, problem creating a metabolic disorder, cardiovascular risk, and other important like the psychological challenges as well. So when we talk about PCOS Awareness Month, I think it's all about raising awareness on various aspects. One is particularly about how best we can combat the underdiagnosis, because PCOS comes with the various symptoms and all those factors that actually result in the very delayed diagnosis. So how best we can use the available modalities from a diagnostics, from a treatment towards really early diagnosis and timely interventions to really control the long-term outcome, the clinical outcome that we usually see in this patient population. So I think that's one important factor. The second most important factor is how best we can raise the awareness not only in public, also in healthcare providers as well. So although we know about like public have very limited understanding, but that equally true for medical affairs professional as well. So I think how best we can give the accurate information about the diagnosis, the symptoms, diagnosis, and the available treatment modalities. That's one. That's the second point. Third, also equally how various efforts we can take to destigmatize the patient, the challenges that we see around the patient population because of the symptoms, right? So I think if we talk really openly about the PCOS and the related symptoms, I think we can contribute towards creating a very supportive, supportive environment or supportive care around these patients. And foremost, I think that's a critical pillar around is how we can empower patients to take a very timely decision, provide that accurate information so they can control their health themselves and advocate to the larger cause. I think we have very eminent and distinguished panelists to discuss various this aspect. I welcome all the panelists on behalf of Roche Diagnostics India and take this opportunity to introduce each one of them. So we have Dr. Sonali Kagne. She is a consultant endocrinologist at Reliance Hospital, Mumbai. Dr. Manjiri Shenoy. She is consultant psychiatrist and head at ICGC chain of clinics. We have Dr. Riddhi Desai. She is also executive board member of PCOS Society and consultant endoscopic surgeon and gynecologist. And Raggaeshree Chanda. She is a PR professional, also joining us. Dr. Shimoni Kadakia, I think she's on her way, will join us very shortly. She is consultant dermatologist and aesthetic physician at Vive, Mumbai. To moderate this session, I invite Isha to take this proceeding forward. Thank you.
Thank you so much, Dr. Sandeep, for setting the context. He's made it really very clear that PCOD, which was a disease, is not a term which we use now, and it is a symptom. And that is why you see there is a multidisciplinary approach. You see many clinicians who are helping this woman challenge and navigate her journey in the PCOS for a normancy and, staying away from all the complications. So to begin with, I would like to ask Dr. Riddhi, what are the clinical signs and symptoms you see in a patient, or what would you tell everyone, what are the signs you should be mindful of and come to the clinician to address that there is some condition underlying? And during what time of journey? Is it only after puberty or somewhere later on also after pregnancy can this symptom or these underlying condition arise in a patient's life?
Thank you, Dr. Isha. And before I actually give the answer to your question, I really need to, place on record my thanks, my gratitude to the whole Roche team for inviting me here. Of course, Dr. Isha and the entire team has been so enthusiastic about PCOS. And Dr. Durusha, who is our founder president of the PCOS Society of India, she gave me this opportunity to represent PCOS Society of India here in this panel. And I am thoroughly impressed with this panel today. It's so unique to see a multidisciplinary approach to PCOS taken up by you guys. So fabulous initiative, especially in the PCOS Awareness Month, which is the September month. So to come to your question, what is PCOS? So PCOS basically is hormonal imbalance. I think that is the most easiest way that I can explain PCOS is hormonal imbalance. Now what happens here is we have our ovaries involved. We have, so the girl might present to us with irregular cycles, with no periods at all for a few months, and then along with that she may have clinical or biochemical hyperandrogenism. So in women we have both male hormones and female hormones. So if there is an imbalance between both, where if the male hormones kind of become a little higher, then we have symptoms where we have thick hair growth all over face, body, or acne. And then now we don't really give importance to this. There was a time when everybody used to say that we've done a sonography and my ovaries are polycystic, so I have polycystic ovarian syndrome. No, that is not true anymore. Now we just call it as PCO morphology, means polycystic morphology. We don't really take that too much into account. I would also like to say something very important that Dr. Isha pointed out, that now it is not called as PCOD. PCOD was the older term where we said polycystic ovarian disease or disorder. It is not the case. Now we have upgraded, our knowledge has been upgraded so much that we know that ovaries are not the cause. Ovaries are now the victims of this hormonal imbalance. In fact, it's a metabolic disorder and we see a lot of other things. So now we know that PCOS may start as soon as adolescence and may continue even till menopause or after menopause. It doesn't go away. It doesn't stop. So this is our new understanding. And just as a side note, maybe you might even hear a new name in the future because now they are planning to change the name of PCOS also. So that is for the future, but yes, now we know that it is a part of a syndrome. There are a lot of other things happening in PCOS. So I hope that answers the question.
Thank you, Dr. Riddhi. And you mentioned a very categorical term, metabolic condition. So that brings me to Dr. Kagne and said, what do we understand by metabolic terms and what are we afraid of? What is the complications which we need to foresee, which we can foresee with a timely intervention, timely diagnosis, and be mindful of having a regular checkup in the journey of PCOS?
To start with, PCOS, if I want to explain it on a molecular basis or on the root cause basis, it is explained very well by the two-hit hypothesis, which tells us that as soon as you are born with certain genes. Like we say, type 2 diabetes is a metabolic disease and it is polygenic in nature, which means there are thousands of different genes which are responsible and which are going to decide whether the person is going to develop type 2 diabetes or not. Similarly, PCOS is also, to start with, is a polygenic predisposition which a woman is going to be carrying, and during her development and at the time of puberty and throughout her life, if there is a second hit in terms of the environmental factors, then that predisposition is going to manifest into the clinical symptoms. And that is where the role of this metabolic nature of the PCOS also comes in. So many of these genes which are predisposing a woman to a PCOS phenotype, they are also commonly seen in a person who is obese, in a person who is insulin resistant, and thereby this is a common denominator on which we have these different phenotypes of obesity, insulin resistance, and PCOS is also one of those phenotypes. What happens here is, again, if I want to go to the basic one issue which happens here is, one is ovarian hyperandrogenism. So whatever are the clinical features, different genes are basically manifesting into these clinical features, be it menstrual irregularity because of the multiple follicles in the ovary, be it high levels of the male hormone in a female person, be it the insulin resistance or obesity, which is going to probably push the underlying hyperandrogenism and the clinical features. All these, when they come together and when they keep on adding to each other, then the manifestations of the disease will come into play. So this metabolic predisposition, if it is there from the childhood, and how would we know about that? So we can know it from the family history. If we have a family history of insulin resistance, type 2 diabetes, obesity, if we have the female relatives, mainly first degree relatives with PCOS, if our mother was having some signs of high androgen, not necessarily the full bone spectrum of the PCOS, all of that is going to predispose us to the PCOS phenotype when a woman is entering into the puberty and adolescence. And so if we are aware of this condition from the start itself, and all of us know that the first treatment for the PCOS is lifestyle modification, maintaining the weight, physical activity, modifying the diet, and all of that if we are aware of, and from the childhood itself if we take care of a very good healthy diet, instead of changing ourselves when we are already having the symptoms, manifestations, if we can train our kids at the early stage itself. And it's not necessarily only about PCOS, it is about all of us. All of us should first accept that we are made to sit at one place for a very long period of time for so many years, and this is going to increase day by day. We should be more and more physically active, and thereby, especially if we are predisposed to these conditions, we should have a special focus on the manifestations. So as far as the metabolic complications of polycystic ovary syndrome are concerned, like these women, almost 50% of them will have these metabolic components of obesity, insulin resistance, even obstructive sleep apnea is quite commonly seen, dyslipidemia is quite commonly seen, the metabolically associated steatotic liver disease, or earlier it used to be called as non-alcoholic fatty liver disease, that is also quite commonly seen in women who have PCOS. So throughout their lifetime, they might have the documentary evidence of any of these conditions, and hence it is very important for us to be aware of this. What happens is, when we know everything, all of us know everything, what to eat, what not to eat, but we are kind of not adherent to what we should be doing. Even though we are putting something in mouth, we know it is not good for us, we are still doing that thing. And there comes the role of some documentation, and there comes the role of some on paper evidence of something is wrong in my body. Because we have seen patients, we are doing the counseling, and as we know, PCOS is the clinical diagnosis. We do not necessarily need the investigations. If we have menstrual irregularity plus minus a clinical evidence of high androgen levels, PCO morphology on the radiology might be present, might not be present. So clinically also we can diagnose it. But once the diagnosis is made, and for us to make the patient understand the gravity of the situation and adhere to the lifestyle modification advices, it is very important for us to document, so that they understand, okay, these are the parameters which are deranged, and therefore I should be taking care of those things. As far as the metabolic parameters are concerned, as soon as we are diagnosed with that condition, or we are predisposed with that condition, we should make sure that we are checking the fasting plasma glucose, we are checking the oral glucose tolerance test, we are looking at the lipid profiles, and we should also, sometimes we see women with kind of grade 4, grade 3 acanthosis nigricans, which is the darkening of the around the neck, which is there for a very long period of time. It is one of the sign of insulin resistance. So when there is insulin resistance, your body tries to compensate that resistance and thereby producing very high amount of insulin, so that at least by producing that high amount of insulin, your sugar levels are kept under normal control. On paper we see the sugar is normal, we are happy. But we should understand that if we have these signs of insulin resistance clinically, which is acanthosis nigricans, it tells me that the sugar is normal because my pancreas is compensating, by it is producing almost 10 to 20 to 30 times extra insulin, thereby maintaining the sugar in the normal range. That means the pancreas is doing overtime for so many years, and that is why the sugars are normal. And this condition is not going to last for a very long period of time. Ultimately, it is going to get exhausted at some point in time. And this is where the role of the testing comes in, wherein if we document that, yes, my fasting insulin level is high, my post-meal insulin levels are high, my HOMA-IR, one of the index which we can calculate, although it's not very clinically accepted, but yes, it gives us some idea. If that is on the higher side, it tells me on paper that the person is insulin resistant. Sometimes we might not have obesity or high BMI as a clinical marker, but still that person can be insulin resistant, and that can be probably diagnosed with this test. Once on paper, the person is very, very serious about their condition. When the reports are normal, the seriousness is a little less, and the adherence to the treatment guidelines is little less. So it is in general, it is not just at the diagnosis, but even on follow-up, because the genetics is not going to go anywhere. We are still predisposed, even though currently with treatment, without treatment, our symptoms are controlled. The chances that I might develop type 2 diabetes or gestational diabetes in future are still there. So we should be keeping watch on our blood parameters at least once in a year or once in 2 years, so that we can diagnose these conditions as early as possible and treat them accordingly.
Dr. Isha, can I just make a point? So sorry. So I think our endocrinologist madam has gone through every single aspect beautifully well. It's just that when it came to investigations part of it, I think I would, always do two things more before I jump to just the diagnosis of PCOS, would be thyroid, TSH testing, and prolactin. I think these two things again fall in her range. I would definitely, if these two are out of range, I would send her, a patient to her and consult an endocrinologist. So these two things, especially very important to rule out. And I think I'd just like to beg to differ about the insulin testing, just simply because I think clinically having it, sometimes patients may just have normal insulin fasting and post-meal results. So we don't really nowadays favor that testing. We'd rather just go into treatment of that with say maybe metformin or inositol. But then that's going into details. But
yeah, so basically we do not advise this test for each and every patient. I might do it for someone whom I see that she is not being adherent to the treatment, and I can clearly see the acanthosis. So it is just to be, prove it on paper, because I have seen that change. Recently, not just a female patient, but I had a patient sent to me to evaluate and rule out Cushing's syndrome, and he was morbidly obese. So looking at the rate of weight gain, the physician has sent me. But when I looked at it, he was overall the darkness and all those things. So when I did the insulin levels, fasting and post-meal, they were in the range of 115 fasting insulin and 666 post-meal insulin, which is probably the highest which I have seen. And the moment that documentation I just showed him, and he was totally convinced about following so not necessarily for the diagnostic purposes, but this is what I generally use it for. Of course, for diagnosis we do not need, we hardly need any of the test. Yeah.
Very beautifully put up by both of you. One important and the third pillar which you all mentioned was about the levels of hormone which is not so high in a woman's body is going up, and there is where we see hyperandrogenism, we see flare of acne, we see brittle nails, we see a loss of hair. So we have with us Dr. Shimoni, who's a dermatologist consultant, and I would like to ask her that do you see patients and then do you deep dive and investigate, understanding there is a deep rooted condition lying in, or do we just treat the acne and leave it there? How is your approach?
So basically, whenever we see patients of acne, of course, acne is a very common condition, right? So everyone who follows up in the OPD, even if they have 1 or 2 breakouts around period cycle, they feel that they have acne. But there's a lot of peculiar acne that you see when a PCOD patient walks in. Maybe they are aware of their condition, maybe they are not aware of their condition. So a typical jawline pattern of the acne breakouts, neck acne, sometimes along the hairline, associated with hirsutism, excessive hair growth on the face. So these are the very classical features where, without doing an investigation or just looking at the patient walking into your OPD, you have a certain mindset that, okay, I want to go around a PCOD history taking. So that is number 1. Number 2, just treating that acne is not going to be beneficial to the patient, because she is going to come back to you again, even after there is a settling of a flare-up episode. So unless you're treating the cause, you're not treating the acne. And any patient, be it a PCOD or a non-PCOD, even if they are just borderline cases, where they don't need an active treatment for with a metformin or with any of the OC pills, you still want to do a holistic approach treatment. It's always going to be explaining to the patient weight loss is a mandate with every counseling. In fact, nowadays we are seeing PCOD in lean. That's another entity. Yes, so it's not that only the obese women are suffering from PCOD. A lot of lean women are suffering from PCOD. We deep dive into diet consultations. We want to improve their lifestyle because a lot of trigger factors are lying only in their day-to-day routine. And just by modifying those things, we are trying to control their period irregularities, not trying to push them in the first visit to an OC pill regime or a metformin regime unless you have documentations in hand. So it's always a holistic approach. It can never be just treating the thinning or treating the acne, because you are going to fail there.
Most of these patients are post-puberty, adolescents, and when an adolescent girl is having acne, flare, thinning of hair, she's probably entering her college and she has a lot of lack of confidence. Body imaging, body dysmorphia is an issue. Is that one of the reasons of depression in these women? Coming to you, Dr. Manjiri.
Sure. First of all, thank you very much. It's very heartening that a psychiatrist is also made a part of this panel, because I think today finally people have realized that it's not just physical health, mental health is equally very, very important. And I think, yes, the number of people seeking help has definitely gone up, and it's only going to, increase over the years. So yes, very nicely put forward panel, and like all of them spoke about all the physical symptoms, and you said an adolescent. So you just imagine an adolescent, a person or girl who's 13, 14, entering her teen years. When we've been there, we've all gone through that identity crisis. We already always have that hormonal issues, that kind of confusion. Am I going to fit in? Do I look good? This is a very normal phase that we say that all adolescent girls, boys, so everybody goes through. And then you imagine, having acne on your face, having blackening of the skin around, putting on weight, etc. And then the diagnosis of PCOD. Obviously, it's extremely disheartening. And like you mentioned, doctor, that it's also seen in lean people. Very much we see very lean people, and, eating disorders, body images disturbance. So everybody knows about anxiety, depression, very, very high rates in PCOS. But I would say even now body image issues or eating disorders are becoming very common. Like, a lean female, but worries, and is diagnosed with PCOS. Everybody knows that weight gain, everybody thinks that weight gain is inevitably going to happen. So restricts her food even more. So that's when we've actually had cases of anorexia, being triggered by the PCOS. So even if they try, they're not able to lose weight, which makes them lose confidence. The acne, the bullying, the teasing that all of us face through, but they take it even more personally. So there is definitely a psychological setback because it generally happens at a very, very tender age, at an age where psychologically we're still struggling to find ourselves, still struggling to find our own feet, and there is still a lot of stressors, you know, college, your admission, your whole career at stake, and then you have this illness. You're put on hormonal medications, you probably think you're infertile or you're going to remain infertile, so all you don't know about your periods, and that's very, very difficult for females, not knowing, you know, about their periods, etc. So I think definitely there are a lot of, like we say, there are certain risk factors for psychological conditions. So all these problems related to PCOS, I would say, are all risk factors. So that's why the rate of anxiety, depression, body image issues, the person keeps looking at themselves in the mirror. The girl will keep looking, oh, I've put on weight here, oh, I've put on weight here. You know, the acne is magnified in her head 10 times, and then, you know, she goes through that emotional struggle. And obviously when you're struggling emotionally, all the medication that all of you give will not help only. So that's where, you know, and they get teased, they get bullied. The parent keeps telling them you can't eat, you have PCOS, you have to lose weight, you have to get more active, you know, and in spite of doing all that, they don't lose weight. So yes, psychological illness, I think, is a very, very important part of PCOS, and I think without that treatment, I'm sure all of you will agree that the treatment is incomplete.
Thank you, Dr. Manjiri. So we've heard from all the experts, and we have with us Raggaeshree, who has so graciously accepted our invitation and is here to tell her story of how she has been navigating PCOS. So over to you, dear.
So I was diagnosed with PCOS when I was 18 years old. That is, I think, 4-5 years back. And I didn't have any such symptoms in the sense. I just had incredibly painful stomachache one day, and my parents were like, okay, we need to rush her to the hospital because it was that bad. And I didn't have any missing periods or anything as such. So I went, and the doctor told me that you have PCOS and you also have fatty liver. And my lifestyle was also not the best. So that time my doctor had said that this is normal, sort of. Like, it's not such a big deal if you just eat well and exercise and, you know, get rid of your sedentary lifestyle, you're gonna be good. But I didn't pay as much heed back then. I still continued because I was in class 12, so I would go out after tuition, have food like junk, etc., whatever. So then it started getting bad because after that we just had COVID, and my body started changing in the sense I gained a lot of weight. I was, I think, 57 to 58 kgs, and another thing I experienced was acne. Now I've always had clear skin my whole life, and then suddenly if you see acne all over your face, I have gone to the washroom and I have cried my eyes out, told my mom I don't want to go out, and thankfully there was COVID, so I didn't have to go out. And yeah, it was very heartbreaking, and I did not seek any medical treatment back then. I googled, I went to Reddit, I went to Instagram. That time I used to Google what is PCOD, what is PCOS, etc. And then I just deduced that I have to lose weight. And I was so desperate enough to lose weight that I think I barely ate. I don't want to promote this, but I ate very, very less food. Yeah, it was so strictly calorie deficit, and I don't even want to say because I don't want to promote that. So I lost the weight, but then I experienced something called mid-cycle spotting, which I still do experience, and that is something that I am struggling with and trying to find an answer. But I never missed my periods, which when I was Googling, everyone, like whoever had to tell their stories, told that, you know, we miss our periods, it's a struggle, etc. That didn't happen for me, which is why it was very confusing that what is going on. And plus, the acne did take like a toll over my self-esteem, because like I said, and I did I did go to a dermat, but they didn't fully investigate everything, that why this was. I did mention, could say that, this is, I have PCOS, etc. But they just prescribed whatever they had to prescribe. That did help. But you're very right with, in terms of that, if you have like one pimple, you're going to magnify that in your head. And I used to do that every morning that I woke up. I would go to the mirror and see that do I have any acne, etc. And once you lose all the weight, it's very difficult to eat more. You just can't. You just can't. It has taken me at least 3 to 4 years to be okay and balance and tell myself, train my mind that it's okay to indulge once a while. It's okay, like if you have like one pimple when your period is nearing, it's not the end of the world. My PCOS journey, I would say, was very confusing, very confusing. There's so much information and misinformation. Someone is saying don't have fruits, someone is saying have fruits, it has sugar. It's very easy to get overwhelmed. In that scenario, I just feel like, and you do feel that you're alone, because when I told my parents, they tried understanding, but they couldn't really like get there. But they've always been supportive. The way I look at it is also, now that I seek medical help, I have a PCOS nutritionist who guides me, gives me like balanced diet, etc. The supplements, etc. are very expensive also. Yeah, for me. So now. Yeah, so now that I'm a little bit financially independent, I just feel like I can seek the help that I want. And because just going to my parents, like when I was like 18, 19, and like telling that, okay, no, I need to do this test, this thing, that thing, it's a lot. That's something like I have experienced also. My journey has been very confusing, a lot of trial and error, and a lot of patience. You need to be very patient. There's no quick fix to this. And I have also realized that this needs to be a habit. Whatever you are doing, whether eating healthy, moving, etc., it just can't be like for 3 months or 4 months or something like that. It has to be a habit. So that's
Thank you so much to share your story. Dr.
So as she rightly mentioned that she went to her parents and she tried to make them understand. So with all PCOD patients, it should be so that you are counseling not only the patient, but you're counseling the entire support system that the person is associated with. Especially the young girls, the parents need to know how to mentally support them, how to emotionally support them. Most of the times I see, the mother walks in the OPD with the daughter. The daughter is a little borderline obese, and I'm telling her to lose weight, but she's not losing weight. Please tell her something. That is something that really demotivates the person who's already mentally affected. So even when we are talking about awareness, when we are talking to patients, we are talking about making reels on Instagram and spreading this awareness. It has to be pointed out that the family should know what this disease is like, how is it going to progress in the future, and how is it not so important in terms of it's okay to go slow. It's okay to be improving over a period of time, and you don't expect magical changes. So that's something that I'd like to add.
So true. So can I comment, please? So I think that is really brave of you, first of all, to come and share something so candidly. I mean, it's not easy to share each and every personal experience out here for everybody. And you know what? You're not alone, because this is the journey that most of our patients see. So in fact, I'd like to say that earlier when Dr. Sandeep was pointing out PCOS incidence is 1 in 5, it has now become 1 in 4. And unfortunately, we are seeing more and more younger girls coming up, and we are diagnosing PCOS earlier and earlier. And the earlier we are diagnosing, it's getting more and more tricky. So what you are going through, that confusing time, is not something different than a lot of other people's story. I'm sure a lot of them who are out there listening are absolutely agreeing and feeling that. Diagnosing PCOS in adolescents is difficult. Sometimes a lot of doctors tend to say that हाँ ठीक है, ठीक हो जाएगा, थोड़े सालों में periods will become regular and periods का issue नहीं है ना, कोई बात नहीं, acne तो क्या छोटा मोटा होता रहता है, hormonal. So a lot of times it gets dismissed. Well, what you said and our dermatologist said, that it is very important to understand the patient when they come to us, young girls that come to us. This is the generation of social media. This is the generation of content creators. They want to look good. They want to look good on camera as well. And I think it's so important. I mean, just an anecdote, I had a patient call me in the middle of the night and said, "Doc, tomorrow is my wedding and I have a pimple. What do I do?" I mean, it's an emergency for them. And we understand. And I think, talking to your doctors who understand, more and more, people who can give you empathy is very important. There comes the role of mental health experts also over there. And I think in your story, when you said it was an absolutely confusing time, I totally understand, because considering that you don't have correct access to that information, what is going on. So I think that is where, instead of Google, I mean, you were in a different time when it was COVID and you didn't have healthcare facilities so easily available. I think talking to doctors is, and of course the role of a mental health expert, specifically going and getting that counseling, very important. That is something that I'd like to highlight. And the other thing I'd like to highlight is the varied presentations of PCOS. Women will come to you saying that, girls would come to you, "Doctor, I'm trying each and everything, right from diet, exercising, and yet things are not getting better. I'm not able to lose weight." And there is this other end of the spectrum where they are lean, thin, and they are like, "We are having so much issues. Doctor, आप वेट कम करने को बोल रहे, खाना अच्छा खाने को बोल रहे, अभी इतना और कितना मैं वेट लॉस करूँ, So that is, so there are varied presentations. That is what you have to understand. If you are suffering, please do go up and speak up about it. Do not be shy and do not hesitate to go and speak to somebody who is an expert. Do not just rely on Google and ChatGPT these days. They may be helpful in a certain way, but best taken knowledge, or just speaking up about it, I think relieves you of a lot of stress. And of course, wanted to just say that I hope you're doing well. do not worry. I think it's and to all the girls out there as well, please seek help. That's important.
From all of y'all, one thing we understood was it has a battery of signs and symptoms, and the patient might land to a gynecologist, to an endocrinologist, to a dermatologist, or to a psychiatrist, but maybe the underlying issue remains the same. So one key message was, yes, it is time to understand, address it, and as ma'am said, looking at clinical signs and symptoms, sometimes we do understand what we're looking at. But Dr. Riddhi, if I have to ask you, what are the bare minimum investigations, or what are the bare minimum, because now we have understood, as you mentioned, there are different cases, so there are different phenotypes, and probably the name also might change. We've seen Stephen-Leventhal syndrome to PCOD to PCOS, and there is something new upcoming. So for a person, if you have to initially recommend certain tests, what would you recommend, and what do you begin with to start understanding and put her on a personalized journey of treatment?
So there are a few basic investigations, routine investigations as such that we have. So I'll talk about that. One is CBC. We definitely need to rule out and check out for anemia. That is one thing for sure that we'd like to do. The other thing I would like to check is for her sugar levels, okay, to rule out diabetes. I already mentioned I would like to test for thyroid, prolactin, and now something which is, so if you already, so what the guidelines, now we have guidelines, okay, and in fact I'd like to just say a few words about that. PCOS has been always so confusing. I mean, it's always like the more you know, the less you know, that kind of a thing. So now we have specific guidelines as to, for doctors, that okay, we go by these guidelines, so that there is uniformity in all the gynacs who are treating it. Not just gynacs, these guidelines for all the physicians, so that everybody can treat uniformly. So if you come to me, you go to any other doctor, we will be doing these set things for you. So initially, all the data that we had was from patients who were not Indians. The last 2 years, PCOS Society, which is a multidisciplinary society of gynacs, endocrinologists, dermatologists, mental health experts, physicians. So we have represented ourselves in these international guidelines, and now these guidelines that we have, which is from 2023, the Monash ASRM. So a lot of these societies got together and decided, yes, now we are going to come up with guidelines for uniformity. So PCOS Society is represented there. So now these guidelines are applicable to all Indian girls as well, Indian women as well. So it says, so we have set criteria. So if you have a clinical hyperandrogenism, means acne, hirsutism, hair fall, hair thinning. So if it is already there, you see these signs, we don't really test. But if it is not there and you are confused in diagnosis, we do a testosterone, serum testosterone free. That is one thing. And now what is coming up is AMH. Now AMH is anti-Mullerian hormone. So it's now a diagnostic blood test which can help you in diagnosis of PCOM, which is polycystic morphology. Now it can be diagnostic. It is a potential marker for diagnosis of PCOS, especially in cases where, so like I was initially mentioning, that nowadays we don't really give so much importance to only ovaries which look polycystic. So a lot of people have nothing, they just have polycystic looking ovaries. So then everybody used to overdiagnose before saying कि अच्छा इनको PCOS है. No, it's not like that anymore. So we call that only polycystic morphology. But because it is so varied, we don't know how many follicles to count and say कि अच्छा this is polycystic morphology. So nowadays we in fact can correlate it with AMH, and in fact Roche Diagnostics has such a fantastic AMH assay. I think Dr. Isha can talk more about it. I think we are using that, and AMH is a good potential where you, for adolescents, I mean we don't use AMH for adolescents much, but where you can't do transvaginal ultrasound, where there's abdominal ultrasound in obese patients, you can't really have access to the ovaries, you may not be able to visualize the ovaries better, smaller follicles get missed. So I think AMH is a potential diagnostic marker. So these are, I think, bare minimum, and especially for patients going for fertility, definitely we do an AMH. So I personally, these are my favorite chosen tests, and that is what is recommended by the guidelines. The rest of them are additional tests.
You rightly mentioned, yes, a lot of emerging roles on new diagnostic marker, but we also try to highlight one thing, that these all guidelines are putting into consideration the Indian population as well. And when we talk about Indian population, Dr. Sonali, I would like to come to you. We are different from how Caucasian population is, or the guidelines are mostly bare basis the Caucasian data or according to their phenotype. How different is Indian population is, and that is why do we really need our personalized guidance or our personalized cutoff levels for our population?
Yeah, you would like to comment something?
No, I just wanted to add to what she said, like how she correctly mentioned the AMH becomes the more specific criteria. Also these investigation panels and the different set of what you would do initially and what you would do as advanced tests, they help you determine what is the plan of action of treatment. So your testosterone levels high, you will choose a different drug. Your prolactin levels high, you will choose a different drug. So your treatment follow-ups and how you want to plan the entire 6 months, 1 year for the patient, that is also dependent on your investigation panels. And that is why it is so important to go through a thorough medical examination followed by a thorough detailed investigation. That's just one.
Thank you.
So before answering the recent question, I would like to continue with the previous investigation part. So we all say PCOS is a diagnosis of exclusion, because just polycystic ovarian morphology we can see in many different conditions. Like we have to rule out thyroid dysfunction, we have to rule out hyperprolactinemia. There is one not very common condition, but there is something called as non-classic congenital adrenal hyperplasia, which can be seen, in which there is high level of androgens produced by the adrenal gland, and to ruling out that, we do something called as 17-hydroxyprogesterone test. So this is also one of the tests which we have to rule out. We have to document that it is normal. That means the whatever are the other symptoms, they are probably because of the PCOS. Another important thing, as we said, PCOS can present any time during the lifetime of a female. They might, I mean, the woman would have a normal regular menses otherwise for many years, but suddenly now there is increase in the acne or some facial hair. In that case, we have to rule out any excess of androgens from the adrenals, ruling out the tumors as well. So we sometimes do DHEAS levels to see if there is any sudden increase and the levels are very high, and again total testosterone to rule out any ovarian androgen producing tumors. Now coming to the question, how are we different from the Caucasian population? So there is something called as Vive paradox. So there were two doctors, Dr. Yajnik and Dr. Yurkin. They were having same body mass index, which was 22, which is normal BMI for Asian Indians. The one, Dr. Yajnik, was from India. Dr. Yurkin was he was a Caucasian. And then we looked at the body fat percentages of both of them. So the one with Indian origin, the body fat percentage was 21%, whereas Dr. Yurkin was having the body fat percent of 29%. So just being of Asian Indian origin, we are more metabolically more predisposed for developing these conditions such as type 2 diabetes, obesity, and we have more visceral fat compared to Caucasians. So even if they are overweight and obese, we are more predisposed even at the normal body mass index, and that is how it makes us different from the Caucasians. And we have to be aware, and that's why the cutoff for the defining overweight and obesity in Asian Indians, they are slightly lower than compared to the Western population. As far as the other blood tests are concerned, sometimes or many a times, probably we find the levels of the testosterone, the androstenedione, and DHEAS, they are absolutely normal, but still the patient has a lot of acne, facial hair. So this is because of the increased sensitivity towards these androgens. So sometimes the reports are normal, but the person is more and more sensitive to the action of those normal levels of the androgens, and thereby they are presenting with those florid symptoms. So that also we need to counsel them about. Most of the times when the reports are normal, they are still worried why my symptoms are so severe. So this is also a well-known fact, because the sensitivity towards the androgen can be different in different individuals, and it might be also be different at different time period of your life. So yeah.
One more question to add there was, is there a specific counseling pointers which you tell your patients when you have to do an investigation? Like if it has to be followed at a particular time, at a particular lab, so that a good serial monitoring is what you require, because these are really sensitive markers. These values are really small, and a little bit of deviation will change your treatment plans.
Yeah.
Any thoughts on that?
Yeah. So once we have decided that we have to order some investigations, I generally prefer asking them doing any investigation as far as possible morning fasting sample, because most of the hormonal assays are not reliable because the hormones are pulsatile in nature. So when you do randomly during the day, the levels are quite different, and if you do again morning fasting, they are much more reliable. So if at all you are going to do a test, and be it any test for that matter, better to do it in fasting and morning sample. And if at all we are asking for the LH and FSH, sometimes we look at those ratios in some women who is having irregular menstrual periods. In that case, we ask them to do it between day 2 to day 5 of their menstrual cycle. And again, about the type of lab, especially when we are doing a prolactin test, we should make sure that we are doing it in a reliable lab. Even about the androgens, because I have seen many patients refer to me for a male patient with a very low androgen level, and I just repeated the test in a good lab and the androgens are absolutely normal. The person was not at all symptomatic, and this happens a lot of times, especially with the hormonal test. So we should make sure that we are doing it in the reliable labs. Sometimes, like for prolactin, we might get the person who is having a lot of symptoms but the prolactin levels are normal, and also the other way around, a woman doesn't have any symptom but the prolactin levels are high. So one of the factors that we can take into consideration is, one is to, sometimes we can ask for a pooled prolactin sample where we take the prolactin levels at 0, 20 and 40 minutes, pool the sera and then run the test in that pooled sample so that if there is any fluctuation we can rule it out. One more important thing, especially for doing prolactin levels, is if the person has taken some anti-acidity medication or if the person is taking any medication by the anti-psychotic or anti-anxiety medications, we have to rule that out because they are known to increase the prolactin levels. So many a times they have already done it, the levels are high, and we just repeat it after stopping those medications or modifying those medications after 2 to 3 weeks and the reports are absolutely normal. So these are few things. Again, for prolactin, avoiding the stress levels. If you are recently traveled, if you are sleep deprived and the next morning you are doing the test can be high. If you are anxious, if you are afraid of the blood collection prick, and that can lead to a very high level of prolactin. And many of the referrals are because of all these falsely elevated levels of the prolactin. Again, sometimes there can be a macroprolactin where the patient's prolactin level is quite high, but the person doesn't have any symptom. It was done for some evaluation by some doctor, and sometimes there can be this falsely high levels because of the antibodies bound to the prolactin molecule, making it a large prolactin, which is biologically not active, but assays are detecting it to be on the higher side. And similar, many variations can occur with the thyroid function test as well. One of that is the hair supplements. The biotin in the hair supplements, they can interfere with the thyroid function assays because the platform that we are using for the TFT assays, it uses biotin streptavidin complex in the stable platform. And if the person is taking up to 5 to 10 milligrams of biotin, which is there in hair supplements, that can definitely interfere. So we need to ask them to stop it 3 days prior to the test.
Thank you. And there I see how everybody is interconnected, where we have the gynecologist taking help or, partnering rather with an endocrinologist and a dermatologist, and an emerging role coming for a psychiatrist. I think for everybody, mental well-being and having the cool mindset and a stable mindset really, really is important. So all four of you, along with the patient who is in the journey, plays a very integral and important part, and we really need this multidisciplinary kind of an approach. So to end the conversation, because we are running out of time, we know that PCOS is not celebrated as a day, as a week, but as a month, and so this discussion can be a never-ending discussion. So I would like to leave you on a very interesting note. What I would like to do is ask somebody to give you or hand over each of you something, and if each of you from your disciplinary actions want to demystify or really burst the myth, I would just like to hand you a balloon. Please say a myth and burst it.
I'll need many balloons. You can give me the whole bunch.
Most common one which and then it's like, okay, high time. I need to say this now right out in the record so that no questions come on.
I mean, talking about my field of expertise, one myth that I'd like to bust by bursting this balloon is that PCOD is not life-threatening, and it doesn't mean that you're not going to get pregnant. And it does not also mean that you're going to have acne and thinning all your life. Thinning of hair.
Like I said, I'll need a whole bunch of balloons because I think there are a lot of myths around mental health. But I think the most important myth is psychiatric medications aren't always bad and they aren't always addictive. And we don't give all all our patients medications, but if it is needed, it is needed. You wouldn't say no to medicines for, say, PCOS or diabetes. Similarly, a lot of mental health conditions at times do need medications. Thank you.
Okay, so like her, I think I have a lot of myths to take up. But one thing, PCOS cannot be reversed. People come and tell me, Doc, PCOS चला जाएगा ना इसके बाद आपकी treatment के बाद. So no, PCOS can be managed. It cannot be reversed. But it is not life-threatening, like she said. It is something that can stay on, but you can manage it without symptoms and you can lead a good life. So please visit a gynaec. She will not always give you medications. We can just chat and have a talk. But please definitely visit a gynaec rather than looking help at, from Dr. Google.
So the myth I'd like to burst is that all your problems are going to go away if you lose weight. All your PCOS problems are going to go away. It's not. It's much deep rooted than that. There are other factors as well, and you should take a multi approach to fix all of it.
Coming to the basic treatment of PCOS, which is the diet modification, and when I see the patient and when I'm counseling, and also the parents are accompanying, sometimes the grandparents are accompanying, and if generally we see obesity in common in the family. So rather than telling my patient particularly to modify the diet, I would like to suggest that the dieting should be familial. A particular child is obese because the food habits were not modified when they start eating. We do not make sure that they are taking a good amount of proteins, fibers from the time they are started eating, and that is when, and also we are kind of allowing them all kind of junk food. A child doesn't know a chocolate or a chips or kurkure unless we give it to them. So especially all the near and dear ones who offer, okay, मैं आ गई हूँ अभी, please take this chocolate. All these things, I think we should stop doing that, and we should stop offering a junk food whenever we meet or greet anyone.
Thank you so much. Thank you so much for a formal take home or addressing the keynotes which we learned.